Hi, my name is Dr. Don Buford. I'm an orthopedic surgeon in Dallas, Texas, and I'm the founder and director of Texas Orthobiologics. I am always very appreciative of the chance to participate in this fantastic spine conference, and thank you once again for the invitation. I'd like to start off with this first talk, which is titled Orthobiologics Use in the Spine. This is the handout that's available. So I consider orthobiologics in the spine. It's really not that complicated of a proposition. Spine surgery, like any surgery, has an infection rate, a failure rate, and a revision rate. Like most surgery, and certainly in most orthopedic surgeries, surgical failures are increasingly recognized as biological failures. We don't need stronger metals or sutures. Our problems now are that we're bumping up against biology. We can achieve the same outcomes with safer, less invasive approaches using human biology sometimes. And in the areas and in the clinical indications where that evidence is mounting, we need to stay aware of that, and we need to take advantage of that. We can improve surgical outcomes by improving biology as well. And again, there's increasing evidence showing this to be true. So one of the things I have to stay aware of is I have to make FDA regulatory compliant choices for my clinic and for my patients. Obviously, this is not an easy thing to do when so many people are trying to give us misinformation. At this point, with what we've known over the past decade to decade and a half, I am still using platelet-rich plasma, bone marrow concentrate, and you can also use adipose as long as it's not enzymatically digested, and as long as you're making adipose using an FDA 510(k) cleared device. Note that I do not use Wharton's jelly. I do not use exosomes, amniotic fluid, placental proteins, umbilical cord tissues. None of those things, to my knowledge, as of today, have an FDA-approved indication, meaning they are not approved biologic drugs. Do your own research. I'm not an attorney. I'm just telling you how I run my practice to make sure that I'm regulatory compliant. This is some of the dilemma that all of us face clinically. Which one of these devices, all of which are available on the market, which one of these is really the best PRP? Which one of these may not even make PRP? Luckily, this information is becoming more standardized. We do a lot of testing out of my clinic, so we can answer some of these questions now in a very public way. Here's just a typical example. If we have a patient that starts with a platelet count of 200, one clinic could run that patient's PRP through a process where they draw 20 cc's of blood. That process may only have a 30% platelet recovery percentage, meaning that that patient will ultimately get a dose of 1.2 billion platelets and 5 cc's of PRP. Clinic 2 takes the same patient with the same starting platelet count, draws 3 times as much blood, 60 cc's of blood, has a protocol that is significantly better in terms of platelet recovery percentage at 80% versus 30%, and also delivers even 1 cc more of PRP. That patient is getting 9.6 billion platelets and their 6 cc's of PRP. Both of these products are called PRP, but the dosage is 8 times different. And the results, they may not be 8 times different, but one may give no benefit and the other may give significant benefit. So we have to know the platelet dose. We have to know what we're using and how it affects the end clinical outcomes. Let's look at some clinical data. Let's look at PRP for the SI joint. In 2020, a nice study was published. It's a level 3 study with 50 patients, and it showed that PRP gave a 2-point improvement in pain score from 1 month to 1 year from a single injection in the SI joint. PRP also gave a 10% functional score increase from that same time frame, 1 month to 1 year. Here's another study that was a level 1 study comparing PRP to steroid injections for the SI joint. This was with ultrasound guidance. The steroid-injected patients were better in the first month or so, but by 6 weeks, the leukocyte-poor PRP-injected patients were better than steroid patients. The steroid was only 25% effective at 3 months. However, the PRP group had a 90% efficacy rate at 3 months. And so PRP was not only better in terms of pain relief, but lasted significantly longer. What about epidurals? There's good level 1 evidence, most recently published in 2023, showing that PRP is a very good biologic drug to use in the epidural space when it's clinically indicated. In this level 1 study, 30 patients were treated. There was a 24 cc blood draw. Patients received 3 cc's of leukocyte-rich PRP versus steroid. The PRP group had less leg pain at 6 weeks, 12 weeks, and 6 months. The PRP group also had better Oswestry Disability Index scores at 6 months. So PRP was better than steroid in a level 1 trial. So when people say there's not evidence, we have so much more evidence than we had even 2 years ago that it's interesting to see how rapidly this is developing. So the question I would ask all of us is, shouldn't we be doing PRP epidural injections if they give better pain relief, last longer, and are safer? Why wouldn't we consider a drug like that, no matter how much it costs or wherever we use it? We at least need to think about it, be aware of it, and consider it. Lumbar facets. This is a 2016 published level 2 study looking at leukocyte poor PRP versus steroid for lumbar facet pathology. Both groups improved on multiple outcome measures, but, and this is a recurring theme, the steroid group results peaked at 1 month. The PRP group continued to improve through 6 months. So yet another clinical indication where PRP is lasting longer than the steroid alternative. And this is even before we talk about the other potential catabolic effects of steroid in these locations and in soft tissues. Cervical facet joints. This study was published a couple years ago now. This is a nice level 3 study, and what it showed that 41% of the patients injected with PRP in their cervical facets still had at least 50% pain relief 3 months after the procedure. So again, multiple locations in the spine where PRP is showing to be certainly no worse than steroid, and in most of these studies, significantly better. And finally, we'll talk about the lumbar disc. This was a nice study in 2016 from Greg Lutz, who we all miss. This was a level 1 study. This was one of the landmark studies looking at PRP for intradiscal pathology. He used a Harvest PRP protocol. This was a single injection done after discography. The PRP group had significantly better pain and function scores at 2 months, and the durability of that result was fantastic. It lasted out to 1 year. Let's change gears for a minute and talk about bone marrow. So why use BMC instead of PRP? Number one, BMC may be a more potent anti-inflammatory based on the increased IRAP content in our bone marrow plasma compared to our blood plasma. Number two, BMC effects may last longer than PRP. And number three, because BMC may be more anabolic than PRP, may get us closer to that true regenerative goal that we're looking for. Where should we get the bone marrow from? My answer is always the posterior iliac crest. It should be the iliac crest, in my opinion, because that's where the stem cells are. You need to draw 2.5 times more marrow from the humerus or the tibia or the femur to get the same number of stem cells that you would get in the same volume from the iliac crest. So that's my source, regardless of my clinical application. This can be done under ultrasound guidance, under local anesthesia in the office. I've done probably coming up on somewhere between 500 and 1,000 now. It's been validated, published, separately validated by other authors. And these videos are available on YouTube under my name. They're free. You can make some popcorn and have a look. The total MSCs in a same-day procedure may only number between 25 and 50,000. So there's not that many. But if you remember about the hematopoietic stem cells and add those in, there's actually significantly more cellular components in a bone marrow aspirate procedure. You have to remember that both immature cell types are secretory. So in other words, there's not much difference between MSCs and HSCs before they reach terminal differentiation into whatever their final cell type is. Both of them create proteins that are exported. Both of them create paracrine effects. They both secrete the same biologically active proteins until they're mature. There's been multiple published papers documenting this. This is a famous one published in 2018. Lisa Fortier is one of the lead authors. And this just shows that IRAP is significantly higher in bone marrow concentrate than it is in PRP. It also obviously shows that MSCs are present in bone marrow concentrate, but not in PRP. So it's a truly different biologic drug. Alpha-2 macroglobulin is another large plasma protein that is in our plasma made in the liver, and it is not increased by the centrifuging process. So if we want to increase A2M with these procedures, we have to centrifuge the marrow, and then we have to filter the plasma, which dehydrates it, and that raises the concentration over baseline plasma levels. So some high-level clinical data. There's not much. Bone marrow concentrate has been used for cervical disc indications. In this level 2 study, you can see there were patients with up to 4 levels of cervical disc pathology, and their scores were still significantly better than baseline 2 years after the injection. So this is a valid indication for BMC in the neck. In the lumbar disc, Kenneth Patine, Matt Murphy, and others did a series of studies looking at a cohort of patients that were treated with bone marrow concentrate. This was a true disease-modifying procedure. They showed an increase in the Furman grade of 1 level at these diseased discs. Only 27% of these patients advanced to surgery 5 years after the procedure, and all of these patients that entered the study had been told they needed surgery. Lumbar disc pathology is another level 3 study. And what this study revealed was that there was a 50% improvement in pain and in the ODI at 1 year from an intradiscal injection of BMC. So another confirming study that BMC is useful for disc pathology in the lumbar spine. So what should I do? 85% of my orthobiologic practice is with PRP. 15% is with bone marrow. And people ask me, why is that? And it's simply because that's where 85% of the data is. And if I'm going to stay evidence-based, my evidence is really with PRP right now, as we continue to develop more evidence supporting the use of bone marrow aspirate concentrate. There are clear conditions in the spine where PRP is better than using steroid. And I appreciate your time and this invitation once again to participate here.